Hello, everyone, and welcome to the May version of our Q&A. And this promises to be a very interesting one. And thank goodness Cindy Kraft is here with me because I think we have a few OASIS issues that folks are asking about. But not only that, we had the end of the PHE last week. The public health emergency ended on the 11th, and there's some changes that occurred as a result of that. And so it should be a fairly boisterous session here. Cindy, how are you today?
I'm good. Um, I'm looking forward to a mix of OASIS, and then there's been some interesting questions about OTs and admits, and kind of what that means as we look to incorporate that. So, but I'd like to also echo that if you have questions yourself, please don't feel like this is a listen only mode for you. Please interject your comment or question, even if it's not what we're talking about at the moment. We love the live interaction.
Yes, we absolutely do. That kind of keeps us happy on days like today. So, you ready to get started?
I am ready.
Okay, this one was a really interesting question, and I think that there's a lot of folks that want to know this information. And this one was actually submitted by a subscriber, and it has to do with risk adjustment, which is always, such a black and white subject, right, Cindy?
Oh yeah.
So, risk adjusted versus actual scores. What are the drivers for risk adjusted scores now? And our agency has noted a significant deviation from their actual scores and their risk adjusted scores, and so especially in the last 3 months. Can you address that one?
Well, I'm going to address it in a big picture because when we're going to really dig into risk adjustment, the OASIS guidance manual does give us, which items factor in with which and what those combinations are. And sometimes I refer to that as the magic of Medicare math, because they've used their statistics and data to determine which factors should influence other factors. I'm not trying to be evasive in my response. What I want to speak to is the context of noticing a change in the risk adjustment in the last 3 months, because that was also addressed in the April Q&As, with respect to reminding folks that they did update the risk adjustment model that took effect with start or resumption of care January 1, 2023 or later. So I think, Sherry, this is partially we're going to have to dig into and look at what those risk adjustment factors are. And maybe we were very used to what they were prior to January 1st, but they did make some changes. And so if we're starting to see that change in that 3-month window, it kind of fits with them changing the risk adjustment model itself. By extension, again, tying it to the April Q&As, there was some discussion about, did any of the OASIS E items factor into it? And I've heard that question several times in preparation for E, and once E went live, how does that factor into risk adjustment? Well, at this point, it actually really does not. In order to determine if these new pieces of information do have a relationship in the outcomes environment, they've got to get baseline data first. So current brand new items are not directly going into risk assessment, with one exception, and that is they were able to essentially crosswalk depression screening in the PHQ 2 to 9, connect them because the fact that the PHQ2 was in the previous OASIS. So that one they were able to make a connection. But every other item that's new does not. What does that mean? Well, it doesn't alleviate some of our concern about looking different because of the changes January 1, but it reiterates why, please, please, why we have to pay attention to the accuracy of every single OASIS item. Because what may be seen as, well, if they're not factored into risk adjustment now, they're not part of PDGM, then, I have limited time and dimes. I'm going to emphasize certain OASIS questions, or I'm going to only review certain OASIS questions, absolutely come back to bite us, especially when you really think new questions. We're talking about transportation impacting their ability to access medical care, when we're talking about health literacy, when we're talking about social isolation. These are things that we've said for a long time do impact how well patients do. Well, in order to make that case, our data has to be airtight. our baseline data in particular to make the case of what should or should not be included in adjustment model. So we have to take some of our passion about some of our patient issues, make sure that the discipline neutral data collection instrument has the best response. It may not make us happy, it may not be perfect because of the limitations of the tool, but I think any concern about this, we have to deal with into what changed January 1 specifically, but keeping an eye on all those new have to be collected correctly as they could create the risk adjustment model of the future or payment or an outcome or whatever, but we got to make sure we're right from the jump.
And Cindy, I'm going to interrupt you very quickly because we're having some breakups on your audio. And those that are listening should know that there is a crazy thing going on with Cindy's Wi-Fi these last few days. Apparently, her Wi-Fi is hosting a family of osprey, which are protected in her area, and they cannot address it until those birds decide to move on. So Cindy, I'm going to chat for a minute and allow you the chance to try and call in and see if that audio would be better if you think. But I know that on the recording, the choppy audio is legible for folks. And so please, I apologize for that as we started. We were not sure how it would affect an audio only webinar, and we apologize very much for the inconvenience of that. But I'm going to kind of give my takeaway on the risk adjustment. Risk adjustment is based on the information that we give to CMS, and it is super crucial that that information be consistent with what you are seeing in the patients and not in any way prescribed by an outside data source or something along those lines. The accuracy of the information that you provide CMS on your claims and on your plans of care is super important for this number to be what you think it should be as they iron out some of these changes with OASIS E. And like Cindy said, they can only do some of those changes and comparisons with the like items that were in the risk adjustment list from the OASIS D data set, OASIS D2 data set. So I'm sure that there's going to be more changes within this year and probably adjustments as they adjust some of the guidance for OASIS E. But again, I apologize for the audio issues. Cindy, you want to try and talk again and see how you're doing?
I can try right now. What does it sound like at this point?
That sounds much, much better. If anybody has
Okay.
any issues, please feel free to reach out into the chat, and we'll pause as we need to and adjust as we need to. Those of you that know Cindy personally, you know that she's 6'2". I can just imagine she's balancing on a stool with her phone underneath her chin, trying to get the best signal possible. So hang in there, everybody. We've got a bunch of questions to get to. And Cindy, I'm going to jump from that one to the OT issue because a user, a subscriber submitted a question that I think will roll right into your question that you received offline. If OT completes the start of care with PT also ordered, that's occupational therapy completing the start of care with physical therapy also ordered, and on start of care, the patient refuses physical therapy but is agreeable to occupational therapy, can occupational therapy continue as a billable service?
Technically speaking, OT still cannot stand alone. And PT would have to go out to see the patient to determine program eligibility. So the refusal of PT in that case would mean that they could not proceed with the OT. And so I think it would have to be very clearly explained to the patient, the situation, the importance of agreeing to a PT eval. And I'm not saying that as some way to shoehorn or bypass the rule, but both were ordered, and the opportunity to be evaluated by a PT and talk about what they can potentially do to keep you safe at home. But if they're in an absolute no way, no how am I letting a PT in the house, OT would not be able to continue.
And that's one of those times, guys, that this is not something that CMS is just parsing out occupational therapy. The ability of occupational therapy to stand alone as a skilling service has to do with some legislation that occurred back in what, 1997, Cindy?
Oh, it's been over 2 decades.
Yeah, I believe it was the Balanced Budget Act of 1997 that imposed the caps on outpatient therapies, and somehow or another, they combined speech and PT together, and OT stood alone. And then there was some typos adjusted to OT not being able to be a skilling service. So what I'm trying to tell folks is that OT will not be able to be a skilling service until they change that legislation, which is going to be very, very difficult. So, Cindy, how about an OT start of care and a PT eval only?
Now, this is where we have to separate out a little bit of history in that we do know that for nursing services, a single nursing visit cannot stand alone as a billable service. There would have to be at least one more. We've run into this issue of a PT eval only in the form of what if it's a PT admit and they only do one visit? Is that billable? Technically speaking, yes, it is. It's not subject to the same have to do more than one visit that's in place for nursing. And that one PT visit as an eval only would absolutely have to confirm qualifying criteria. And I would say should never read as I did this to open the case for OT. Sometimes I've seen it. I've seen it, Sherry. I've seen nursing put that down. I've seen, I did it to get the case open for. You can't do that. But absolutely, if I went out and did my assessment and I determined program eligibility as a PT, and I do not see an ongoing need for my skilled care, and or the patient has said, go away, leave me alone, then I would say, okay, I have established eligibility, OT can continue. Now, Sherry, for a brief second, I want to soapbox a little bit more than that.
Okay.
What I find, though, in those eval onlys, more often than not, is that some sort of program was given, recommendations were made, suggestions were made. Okay, so if that's the case, then I would expect one more visit from PT to determine that if what you suggested, recommended, or gave them was actually effective. And I'm not the one saying I expect it, you should do it because Cindy Kraft said so. If you look at the regulation and the coverage criteria, CMS expects to make sure that we haven't inadvertently given them something that is no use to them or potentially hurts them. So that may mean that, okay, I'm a staff, I do my eval and I've set you up and I'll come back and see you in 2 weeks as the PT. I can absolutely do that and I should do that. So I think that eval only, we got to really look at the content of it. But in technical sense, one PT visit could determine that and OT continue.
Oops. That is a great point. And I think that people need to understand that this is one of those things that can trip you up on an audit, and it's low hanging fruit for an auditor, guys. So we need to make sure that we're being as diligent as possible and providing the patient everything they need and staying within those frameworks. And here's the thing that gets confusing. We found that all of the, all the folks in Medicare Advantage, which is now, for everybody's edification, has now usurped 50% of all home health beneficiaries at this point are on some sort of Medicare Advantage. They don't carry necessarily the same rules that traditional Medicare does. So keep your agency within those rules that are on the Medicare side, because you do not want to mess up that reimbursement source and by proxy, just to take one thing off somebody's plate because they have a Medicare Advantage. Does that make sense what I'm saying, Cindy?
Yes, but I also want to make sure people don't overreact to this in terms of, see, this is why we don't have OT admit. That there's these risks involved, or it shocks me to this day there's still agencies that don't let PT admit because that something could happen, or it's too confusing, or it's just easier that way. But I want us to just be aware. And I got some questions sent to me just this morning with respect to issues related to the OT admit. And what I want to just kind of pull from that to add to the conversation today is questions like, what are surveyors looking for related to OTs doing start of care? What kind of care coordination is necessary to perform? Through these questions, different. It isn't different. That a surveyor coming in and looking at an OT admit would be looking for everything else they normally would be looking at in terms of compliance. with the clear exception of has the qualifying criteria been met, as we already talked about. But in terms of beyond that, it would be the same expectations for compliance. It would be the same expectations for care coordination. And so I look at some of the questions, Sherry, and it's like, well, when would it not be appropriate for an OT to do an admit? And I'm going, huh? What are your thoughts on that, Sherry? What would you say if it was, what are the instances that OT should not be the one doing the start of care? I mean, with the exception of thanks to the end of the waivers, we are back to being stuck with if nursing's ordered at any point, they have to do it. The question of should they have to, but your thoughts on a question about when it wouldn't be right for OT?
I'm not sure, honestly, Cindy, except for possibly a wound being the primary reason that we're going to see that person, is particularly a wound on the trunk or the lower extremities. I think that would be one of the niche things that maybe an OT wouldn't be the best qualified to determine what the reason for the plan of care would be. But as you know, I am team OT, big time. I think that patients want nothing less from their home health experience than to be able to return to their level of function prior to their event coming into home health. And I think that OT is horribly underutilized in home health. And so, Cindy, I don't know if you have another example, but that's really the only thing that I can think of, or something that was a disease process, like a urinary disease, or maybe a horrible brittle diabetic. But other than that, that's very case specific.
I really, Sherry, I couldn't come up with any, honestly,
Yeah.
because whenever we go out to start care, we go based off of the information that we have. And the job of a thorough assessment is knowing when you've reached a point where another service needs to be ordered. So even if the order came through, and I just used this example earlier this morning, I still remember getting the order to me to go do a PT admit, and the diagnosis was UTI. And I'm like, what? What? I'm not doing anything with the UTI specifically. But you go out and then you look, and this was before the face-to-face. I think that UTI thing would have been taken care of faster. But you go out there and you assess and you figure out what's going on. And there was plenty of times where it was a PT only, and I ended up saying, okay, we need an order for a nurse, or we need to get an aide, or we need to get other things added. I'm completely confident OT can do the same thing. If they go out there and look at it and say, oh gosh, look at all the medications in a bowl like a candy dish, and they don't know what half of them are, I'm getting a nurse order. I'm not even going to think about it for more than 30 seconds. Or if I'm seeing this wound that nobody mentioned on the referral, yeah, we're going to have to get wound care taken care of. So I think it's about, confidence that OT, much like PT, speech, and nursing, isn't going in there and just looking at one thing. They are looking at all of it to say, do I need to bring in reinforcements? And so the suggestion I made earlier today about this whole OT admit thing, if I had any advice for agencies that are moving in that direction or reinforcing that direction, please try to make it a positive experience that they're doing admits. Let's just be honest, RNs and PTs have done terrible PR in this department for decades, complaining about how long it takes and how miserable it is and all these OASIS questions, blah, blah, blah. We've done a terrible disservice for anyone whose OTs may be going, I don't want to do this. I don't think so. Or this sounds awful. Please don't sign me up. I think we have to take some responsibility, Sherry. Well, I can take personal responsibility. I may have caused part of the problem. Although I have been at the pulpit, as it were, for a while now, saying I have been keeping track of how many PT admits I've done, because once OT got the ability to enter the sandbox, they were going to have to work to catch up. So I do think it's got to have a positive spin to it in the organization and support, because we've made it sound so onerous. Who on earth would think this was a good idea that they get to do it? I mean, OTs have been battling, some of them, with their own professional associations saying, shh, 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 we don't want to do admits, be quiet, we don't want to. So reinforcing this as positively as we can will be a huge part of it being successful.
Well, and Cindy, I'm going to echo that this with the staffing situation that we have in home health right now. I think it's all hands on deck. I think that it's all hands on deck to get that start of care visit finished, so that the care can occur in a timely manner. Right now, it's affecting mostly nursing and aides, but I know that it's not the easiest thing to hire therapies as well. So just be aware that you want to keep your triage on point and make sure that patient's getting the care they need as quickly as possible. Now, Cindy, I want to remind
Well, before we
everyone.
leave that though, Sherry, I want to do a little tiny call to action reminder.
Okay.
I do know that the National Association of Home Care has been pushing CMS initially to try to stop the end of the waiver related to therapy being able to admit even when nursing was present. That was unsuccessful in terms of meeting it by the deadline last week, but what I'm hearing is conversation is not over. It's being made clear that in the current staffing situation, the idea that I'm holding off other services because the nurse is the only one that can admit is not a good idea, as well as the fact that even if it's quote compliant, I could have, as the PT, admitted them this afternoon, but now I can't do it till tomorrow because the nurse can't go till tomorrow morning, is a delay in care.
Mhm.
It's still technically in the time window, but it's still making people wait. And so please pay attention to newsletters and updates. We're going to keep, passing on as much information as soon as we get it. But I don't believe that that battle is over. And if we've seen, as many agencies have, the ability to be more flexible as a positive and are realizing in the last week that now I have to go back to telling my nurses, you have to do all the admits, has probably not gone over that well.
Exactly. And I know that we're still having a little bit of auditory issues, Cindy, but I want to point out to everyone that if you hit the CC button, we do have it being transcribed, and that will be on the recording as well. And so far, the transcription is picking up almost everything Cindy's saying. So again, we apologize for this thing, but we're protecting the Ospreys here. Cindy,
Hey, and Sherry, this is home care. We have to
yeah.
be flexible. I just never realized that I would have to compete with a protected bird sitting in my internet tower or keep my windows closed so you guys can't hear notes from the neighbor.
Yeah, it's the beginnings of a country song, Cindy. Like I said, it's got the bones of a country
Absolutely.
song. But I wanted to remind everybody also that you can still submit questions, and folks are doing it in the chat box or in the QA box. It doesn't really matter to us, but wow, we love this interaction. This is exciting for us. So I want to get to as many subscriber questions and as many attendee questions as we can. So I'm going to take a dive into the pool of Oasis E, Cindy, if that's okay.
Sure.
Okay, here's my question. If a patient has an order for an antibiotic to be taken only before dental procedures, is that antibiotic entered into N0415 high risk drugs if the patient doesn't take it at all during the home care episode?
Okay. So I think that, first of all, you're going to hear several references anytime we're talking about Oasis today to the April Q&A. I think the April Q&A, in my personal opinion, is the best one we've had so far with respect to Oasis E issues. And I say that because you can really tell by these questions that these are real questions. These are not kind of, I looked at the manual a whole lot and I'm hypothetically coming up with something that may happen, which I believe was a big part of the Q&As the end of 2022 and the one in January. And I think that also reflected in the answer getting, which seemed to be a whole lot of cut and paste what the manual said. So it's like I asked you a question and then you basically sent me back the manual we already had. Where am I going with this? Well, the April Q&As really do seem to want to speak specifically to real life situations. And N0415, I'm tongue tied on that one, is definitely one that's been causing some issues with respect to that. So what we see is there are questions about that, and I'm trying to find the right spot here because I had it teed up. Maybe that bird messed up that thing too. The issue is that at the time of the assessment, they don't have to be actively taking the medication. Is it on their reconciled medication list during the time they are a home health patient? So if that medication is ordered related to dental procedures and it is part of what they have access to over the course of the home health episode, it is not tied to whether or not they took it at any point during the home health episode. So that is part of their routine medication. It's there for what they have to take before dental procedures. I would say, yes, it would need to be listed based on the contextual guidance we've been given about it doesn't have to actively be taken to be counted for that.
And Cindy, I kind of agree with what you're going with there, and the guidance is very clear. And I wanted to let our listeners know that I will send out the link to the April Q&A for Oasis E, along with the recording link for everyone, because that's how important it is. We think that you guys are able to get this to your staff and have them start using it. And I'm showing a slide here about our Oasis E assessments. These are tests that you can give to your staff, to your review staff, to your administrative staff, and it basically just lets you know where you are with Oasis E, where you are with the knowledge and fluency. And with that, you get a report. And the reason I'm highlighting this, I don't want to market everybody to death, but the reason I'm highlighting it is we have a significant sale going on with this per user at $30 per user until the end of this month. So if you have any questions about that, please get our emails at the end of this session, and we can definitely let you know more about that. But folks have been taking this, and it allows you to focus the education that you provide your clinicians, that you provide your review staff, and it makes sure that everybody's singing off the same sheet of music. Cindy, you ready for another Oasis E question?
Well, I want to add to that real briefly, Sherry. Whether or not you use that product, my concern at this point as an Oasis reviewer and in talking with our folks on the outsourced coding and Oasis team is that quite a few of the new questions in Oasis E require interview and have very specific definitions. I think the majority of agencies did a good job trying to prepare staff with education at the end of 2022. And then we got into 2023 and we're relying on a review process, whether internal or outsourced, to determine whether or not they understood it. What I'm finding in writing some of these knowledge-based questions is I'm not sure some clinicians are really understanding the directions and asking the questions correctly. And let's just be honest, you can't catch that on review. As an example, we had a recent scenario question about the time frame associated with the transportation question. And we know the transportation question doesn't include a time frame in the item, but the guidance manual says it's the last 6 months to a year. Clinicians are missing this question at an alarming rate of giving the wrong time frame. Well, if I'm a reviewer, if I'm looking at this and there's an answer to the transportation question, unless I'm going to have them wear body cameras, I don't know if they said in the last week instead of the last 6 months to a year, or they assumed it was within the last 3 months, or before they went into the hospital. Did they come up with their own kind of context for this? Because we're not supposed to. It's supposed to be 6 months to a year. So I just suggest, as we look at our Oasis accuracy and our need to be vigilant in that space, the Oasis review process in and of itself might not catch it all right now. And I also think that's an opportunity with respect to how we utilize supervisory visits. Do we need to make sure we tie them to an Oasis event to observe how the clinician asks these questions? Are they reading them exactly as written in the ones that you're supposed to do that? Are they doing the pain ones in the order it specifically says? Because we have to make sure if they're not, then we could be getting erroneous answers in our document and not a really way from any review standpoint to find. So that's not an extended by the K&K one. It's just an option, but it's something you need to think about as you look at your reports and say, oh, these are the ones that cause us problems. It's always the functional questions. Be careful about some of the others, because I'm unearthing people not understanding about proxy, thinking that they as the clinician are the proxy. If the patient declines, putting an answer anyway because their observation gave an answer. These are all things that guidance manual told us we couldn't do. I'm just not sure how well it's permeated out to all of the data collectors.
Okay, Cindy, I have another question about the Oasis, and it's your favorite subject. Can you hear me?
Yes.
Okay. Could you please address the correct way to complete the BIMS and PHQ 2 to 9 when you need to complete a discharge with no visit? So those questions were not asked. Example, would the patient you plan to see again next week to finish education and discharge, they go to the doctor this week and are discharged to drive, and they call you and cancel any further visits before they're headed out of town? I know that the last qualifying clinician will refer to their last visit and can use other discipline notes in the last 5 days prior to discharge for most of the answers, but the BIMS and PHQ-9 are specific questions and require patient response. Please clarify if this is when a dash is used. Also, please clarify when to use dash versus the code 99.
Okay, first and foremost, anytime we're stuck with a non-visit discharge, what we're really trying to come up with is a workaround, an acceptable, allowable workaround. It is never the ideal circumstance. And so I think it's important with well, they called and they don't want me to come anymore, to remind folks we need to make every effort, short of going there and kicking their door in, to say why we need to come back for a final assessment. Because I think sometimes when we're very busy and we're short-staffed, the patient refused is like, okay, good, freed up space, now I can go see somebody else. They won't let me in. Okay, we need to make sure we've really, really tried to the best of our ability. But if it's push comes to shove, no, they will not let me come back. You are correct in that example that a dash would be used with respect to the BIMS and the PHQ-2 because I don't have that information. I can't infer that information. Now, if fluke, I'm just going to call it a fluke, somebody in that time frame did one of these, that I could use it, but it's highly likely that nobody did. And without that information, a dash is what we would use. I would argue when they keep saying how a dash should be used infrequently, a lot of this dash does come out in the non-visit discharge, because this also comes into play on questions that you're supposed to ask the patient. Well, if I can't ask the patient, I don't have the information, and that often drives me back to the dash, because the dash, again, is intended to be rarely used, but in a discharge no visit, if I don't have it, I can't just infer it. So 99 is the summary code with respect to if the assessment was not completed. But in terms of the individual items, yeah, I would anticipate a significant number of dashes on that assessment.
Very, very good. I think that's a very interesting answer, particularly with the BIMS and PHQ-9 and all the proxy issues that are associated with that on the start of care.
But Sherry, we're still seeing the other end of this issue, which is I totally understand the non-visit discharge and we could not complete the BIMS or the PHQ-2 to 9. What I'm not understanding in May of 2023 is how we're still seeing people try to put no on C100 about the BIMS, or trying to argue that they're not completing it, or the patient doesn't need it, or the patient's refusing. We're seeing a lot of it in the outsourced space. I really thought this was a early 2023 issue that would resolve. It doesn't appear to be. Our OASIS testing product is showing the same thing. We give folks a scenario where the patient refuses to participate. How do you answer C100? And we're getting way too many of them saying no. No is not the answer. No is if the patient cannot be understood or rarely understood. So what I would strongly recommend, if you have not done so already, is yes, we could say they should go look in the manual. Well, if you look in the manual for the BIMS, there's pages and pages and flashcards, and it's all great stuff, but no clinician is actually going to sit down and look through that. So I would say some sort of a cheat sheet of what are the steps when a patient really refuses. So let's first deal with, this is not, do you want to do the BIMS question? It's not, do you think it's appropriate question? No, it basically says attempt to complete on all patients in the item itself. But the steps of, if I have a patient flat out refusing, I can totally understand you because I understood you refused me. I have to put yes to that question. Then I have to go to the next 4, and they should be scored 0, because 0 in those cases either is the incorrect answer or no response. And once I get through the next 4 individual pieces as zeros, the instructions kick in about stopping the BIMs, which means I dash the rest of it in C400 and put a 9.9 as the total score.
Mhm.
Now, when you say it out loud like that, Sherry, it's like, oh, okay, I can do that. I can follow that. But I think the time has come to spell that out in whatever convenient way is possible, because the continued no and then not filling in the rest, and then the patient can be understood in every other part of this assessment, just not there, is really going to mess with our data long term and look extremely confusing to CMS.
Okay, I have another item question for the OASIS E. Are you ready for this one?
Yep. Uh-huh.
Okay, this is for GG0170. Mobility questions in M1860 ambulation. How do people know your favorite item, Cindy? I need to know that. If a patient is independent, sit to stand, and ambulates 10 foot, but requires supervision for all ambulation beyond 10 foot, all surfaces, is M1860 a 2 or a 3? For the same, if patient is supervised sit to stand and to ambulate 10 foot, but not safe beyond that, is M1860 a 3 or a 4 or a 5? Question mark.
Okay, so there needs to be a degree of harmony between the M1800s and the GGs. And I say harmony because not everything matches up clean. We know that in GG 130, there is more what appears to be direct connection when you start talking about toileting hygiene and bathing and lower body dressing and upper body dressing. There's very familiar language there. Where it gets weird is what you just described, that in the M1800s, we have one question about ambulation. And then over in the GGs, we've got things broken out to sit to stand. We've got different distances. We've got turning. We've got steps. We've got all kinds of fun stuff over there. First of all, we always have to remember that in 1860, the transfer is irrelevant. If you read the question, it says upon standing. So how they got to a standing position is excluded from 1860. Always has been. This has never been about boosting people out of chairs. The need for assistance to move and get up and get to another surface has always been embedded in a transfer question. 1850 does account for sitting up in the bed, standing up from the bed, potentially getting to the nearest seating surface. So how you get to standing, how you get to the wheelchair is not part of 1860. And we know that 1860 is not distance dependent. There is no mention whatsoever in that item about distance. So when we're trying to differentiate between a 2 and a 3, the issue has always been, does this person need intermittent assistance of another person, which is a 2, or continuous involvement of another person, which is a 3. So when we look at this and say, I'm trying to figure out a better way to move the conversation, because I think we've talked about it so many times, we forget things. A 2 is I'm saying my patient is intermittently safe and able and independent with ambulation. That's what I'm saying. I'm saying on surfaces, they are magnificent. I only think they need help in certain parts of the home, or if we go outside. It's about intermittent. It's not defined by equipment. So it's about their level of being safe and able, it being, I need to be at least supervising them on an intermittent basis as a 2, or someone should be at least supervising them the entire time they're up on any surface that they're dealing with. So in a situation where we're saying, you know, they need help to get up, well, that's the sit to stand transfer issue in GG. It has no bearing on 1860. In 1860, the issue is, all right, of the surfaces they have to traverse once standing, do I think someone needs to be here all the time? And I would say if someone can make the 10 feet, but after that is unsafe, I'm going to go with my gut that they need at least supervision that first 10 feet anyway. I've never seen a patient that is completely safe and able for 10 feet and then falls off completely at 11 and suddenly becomes unsafe. So I would say that that description would be baseline as a 3. I would not be going to the chair fast response unless this person, no matter my attempts to help them, is unsafe. I mean, just completely, I'm going to remand you to the chair. Don't do this until we've done some significant work on improving the quality. I am remanding you, and my documentation would have to reflect that. But I think, again, the sit to stand transfer is not part of it. Distances are not part of it. We have to focus on the intermittent versus continuous involvement of another person.
And Cindy, the remanding to the chair reminded me of the person who was going to be arrested from their home, but told the arresting officer they could not leave because their Medicare Home Health had beat them homebound. So I apologize.
I love that story.
Yeah, that's one of the great stories of the world. And you guys, these things can be really confusing. And the GG items are a new item for many of us that work in home health. They came in, I think, in OASIS D2, right, Cindy?
Yes.
They're a part of the Impact Act that is law. And the purpose of the GG items is to try and get uniform screening across the post-acute spaces in the hospital, skilled nursing, rehab facilities, all these things singing off the same sheet of music. These GG items are not going away, but it's super important that you try to get them, again, as accurate as possible. And I brought a slide in today because a lot of folks don't know that we do outsourcing, Cindy, and I love this slide because on the left-hand side of the slide, you see somebody with their feet up in their Chuck Taylors, just relaxed and chilling out. And on the right-hand side is where most of us in home health sit almost every day. And that's a choice. We provide services that can make the headache go away when it comes to auditing these issues. And I think it's super important that you have that in place as a QA, especially with the QA regs coming back full force since the pandemic has ended, that you have that opportunity to get the accurate things that are sent off that can be defensible, that you're not going to be at risk for audit. Cindy, easy OASIS question. Does a Medicaid certified agency, non-Medicare, providing home health aid services have to do an OASIS assessment on patients older than 18?
Can you repeat that one more time? I want to make sure I didn't miss part, Jerry.
Does a Medicaid certified agency, meaning they're non-Medicare, providing home health aid services have to do an OASIS assessment on adults 18 plus?
It is my understanding that that is no. Just if we're talking providing aid services and not skilled services, then OASIS would not be part of that requirement.
And I have another item question that just popped into the Q&A box, and I love these because it talks about the gray areas of the OASIS. Transfer scoring. Most patients are a 2 at start of care and a 1 at DC, not showing much improvement. Can you give examples when we could use a 3? The scoring is so gray. We feel you, Amanda. We feel you.
Well, first of all, we have to keep in mind that this is really not about grades of improvement. The math is simple. Are they better than when you started? So if I get a 2 to a 1 or a 2 to a 0, I don't get bonus points for hitting 0. I think that that's kind of how we've added layers to it. And that's why we've gotten mad at some of these OASIS questions by saying you don't get a whole lot of room to work. But when I move the needle has been moved. So if I look at it and say, well, if I got more 3s, then I would show more changes to 1s, that honestly would not make you look better. The issue is, are they at least 1 level better than when they started? The issue with 3s is we really have to look at and say, how impaired is this transfer? And typically 3s come into play when we're talking about Hoyer lifts. So individuals that are out of their bed, so we can't use bedfast, but they are not really participating in this transfer. So they're being mechanically lifted or deadlifted by a family member. They're only out of the bed potentially for short periods out of the day at a minimum. That's typically where we see that particular score come into play. But we never want to approach it with, how do I make it look like there's a wider jump in improvement? That doesn't really change our outcome measure, especially when you look at value-based purchasing. The whole issue of functional improvement there is based on composite scores. So even better than what makes our star ratings right now is that it's about net gain. not requiring that I'm getting a better in every single one of those functional areas. Can I overall improve them? I may have, some of them end up stabilized. It's the same score as it was at discharge. But if the other ones improved by one level, I've improved the majority. And so I have a positive patient outcome from a bigger picture. And trust me, as someone who was involved with the technical expert panels leading up to value-based purchasing, that was quite a ruckus discussion to say we have to stop looking at the measurement of function and improvement as if we're going to improve every single element of function given our patient population. We want to, sometimes it's not realistic. So by putting it together, it's a better representation of the impact of our care, as opposed to trying to move the needle on every single one of them separately.
And as I'm trying to get to more of these questions, Cindy, we have another item question that popped in, and I think that these are super important that everybody gets on the same page with these items. So can you address M1860 ambulation and M2020 medications? If a patient needs supervision to ambulate at all times, M1860 equals a 3. Is M2020 always a 3 for patient needing supervision to ambulate to where the meds are stored and or obtain a beverage to take the meds with?
Well, one of the mantras I have when it comes to many things regulatory wise is if we're going to ever say always or never, there absolutely has to be a definitive source for that.
Yes.
Because the only time I'm willing to follow an always or never is when someone shows me that the powers of CMS or the OASIS gurus or whatever have proclaimed that there is always this relationship. In the case of 2020 and 1860, there is no always. I will repeat that again. There is no always. I think where this came from, and it was a good thing, that when we started collecting 2020, we did it as clinicians. And we said, this is about their medications. And this is about knowing what to take. And this is about knowing when to take it. And it's about the drug regimen review. And it's about interactions. And it's about duplicates. No, it's not. This question has always been about the functionality of oral med management. The drug regimen review and interactions and duplicates and side effects all lives in item 2001 when you're looking for clinically significant medication issues. But in 2020, this is about knowing what to take and when to take it. But that also means getting it from where it's kept. And so when that conversation started becoming more prevalent, it made us go, hold it, this is also tied to function and mobility. Yes, but that tie is not, if 1860 is 3, you are an automatic 3 in oral med management. I have to look at the patient's situation. So I could have a patient who absolutely is a 3. Anytime that they're up, they need to be supervised while they're walking. They keep their medications in a pill planner next to their bed, and they can access it and use it and don't have any problems with it. Okay, their 1860 is still a 3, but they're not making any mistakes with their medications, and mobility is not impacting their ability to do right dose, right time. So I would not put a 3 down on 2020 just because I said a 1860. So I think this kind of has gone the way of what's happened with homebound status. That we felt as an industry, a solution to make it easy is to say, you're going to have to talk about homebound status every visit, every time. The problem is that has watered down the power of that statement and led to problems. So anytime we're now trying to say, I want you to consider function for 2020, it's easier to say, if 1860 is this, you have to put that there. But that's not supported by the guidance manual, and that's not supported by looking at individual patient situations. So I should consider it, but it's not an absolute, because the patient may have come up with, or their family, a better place to put the medications, and there are no oral medication issues, and they are managing it, and the mobility issue is there, but they've already figured out how to work around it for meds.
And Cindy, I'm going to give you one more item question, and then I'm going to have to draw that to a close. We have about 10 minutes to go. If a patient requires supervision to get to the bathroom and does not have a commode, what would be the best way to score them in toilet transfer 1840? OASIS guidance does not seem to cover this.
so they don't, make sure I understand, they need supervision to get to the toilet,
Huh?
and
To
they
get to the
don't have a
bathroom.
bed.
Yeah, to get to the bathroom.
Right,
And
correct.
they don't have a commode.
They don't have a commode, or they don't have a bedside commode.
I think it's a bedside commode.
Okay, it's because I want to peel the onion just a little bit.
Yeah.
That question is talking about the patient's ability to get to the toilet in the bathroom, on the toilet, back up from the toilet, and back out of the bathroom. It is an all or nothing question. So the minute you're saying this person needs supervision to get there, we already see where this answer is going to go with respect to the reminded, supervised, or assisted, because even if it was just help to get there, but not on and off the toilet, help at any component defines that response. Now, there's been questions over the years about certain home situations, to the point where there have been questions about what about patients with outhouses? What if the bathroom is so horrible that the toilet is just terrible and broken and they don't even go in there? If they can't access that, if there is no toilet in the house, then they are not completing the question. And we have to look at a more aggressive answer, because they're not accessing the toilet in the bathroom as the question describes. I would say that that is an extremely rare situation, but it could happen. Now, if the question really was that they need to help to get to the bath, they don't have a bed commode, you can't use the bedside commode answer unless they A, have one, or B, you've recommended one and one's in process, or you've recommended one and they've said absolutely not. A bedside commode could be part of that. Please don't turn that into an always, because it's not an always. What I want people to do, though, and what I suspect is part of this question, is I think agencies are frustrated with that question because the organization of the responses appear to make it very difficult to show much of an improvement. That, okay, if reminded, assisted, or supervised for any element, it's a 1, and guess what? It's probably going to be a 1 at discharge as well. How do I get more people to be other numbers? I've seen agencies say, well, we're going to put everybody as a 4. Okay, you can't do that. And again, toilet transferring is not part of our publicly reported outcomes. It is not part of star ratings. And its factor into value-based purchasing, you also, again, we're back to net gain. We're talking about composite scores. So yeah, the way it's currently written, a lot of patients start out as 1 and they end up as 1. They end up at this same level. Any question where that happens, because we're following the instructions, it's annoying, but we have to make sure we follow the instructions. And temptations to try to figure out how to make them look worse so that there's a better chance of looking better, always we have to be careful with that, because does that fit the official guidance? Does that fit what the clinician is seeing with the patient?
Great answer, Cindy. I want to draw everybody's attention to the slide that I just put up that has our contact information. If you have any questions or anything that comes to mind after this session, please reach out to us. We'll answer you as quickly as we possibly can. And as soon as we get the recording of this session, it will be placed onto our YouTube channel. So take the opportunity. I'll be sending the link out to all registrants, and I'll also be sending that copy of the April Q&A for Oasis E. Make sure and subscribe to our channel. It is all free educational information, and you can access those whenever you want, and you get notified when we post new things. And we'd love to have your feedback, particularly on our unfiltered productions, where Cindy and I typically get a little bit off the rails and let the filter down a little bit and speak freely about home health and some of the frustrations that we all experience in home health. Okay, Cindy, some agency type questions. I have 3 quick ones for you. First, can a PTA, OTA, or LPN, I'm going to add those all in there, perform a disciplined discharge?
Okay, I know I have to be brief in this answer. In the technical sense, you have to look at the state practice acts that they may be influencing this. From a bigger picture, we don't have specific regulation for Medicare that they cannot do the final discipline visit. Clearly, they can't do the agency discharge. There's nothing that specifically says they can't. But respective professional associations, and by extension, practice acts, have had a very different opinion. To say that that last visit is an assessment visit which means a PTA or OTA or LPN should not be the one doing it. And I know there are many home health agencies that have adopted that and say that that discharge visit has to be done by the PT, by the OT, by the RN. And I think it's more of an issue in the PT/OT space because typically an RN discharge is an agency discharge very often, and wouldn't fall to the LPN. But personally, I think it is an assessment level visit, and I do lean toward having the PT or the OT be the final eyes on it with input from the PTA or the OTA leading up to that. But don't take that as that's a rule. I would check your state practice acts if there's anything speaking to that. And if the consensus of the group is that our agency is going to go to that standard, make sure we understand we have that documented in policy if needed and that we'd be surveyed against it.
And as a PTA, Cindy, I think that it's super important, again, that you go to your state practice act. But in Florida, I can speak to Florida, I cannot perform assessments at all as a PTA. I can only gather data that I can provide to the PT, then upon which they can perform an assessment. So I think that it's super important that if you're going to do this in your agency and you find that the Practice Act supports it, that you make sure that there's distinct notification of communication between the assistant and the 4-year license, between the LPN and the RN, between the CODA and the OT, between the PTA and the PT, that it says very clearly that there was a conversation and that any results of the visit that resulted in a discharge occurred after that conversation. I hope that makes sense. It seems to be laborious, but sometimes it's super important that we write that down pretty succinctly. Okay, another agency questions. When would the home health agency use an HHCCN form? Do all physician order changes need to be reflected on the HHCCN? That's the home health care change form. Took the place actually of the HHABN. That is the one I'm more familiar with. Cindy, did you have any response to that one?
I'm deferring that back to a former agency owner, Sherry. You can take that one.
The HHCCN is for changes to the plan of care when you're taking something away from the patient. I would argue that if you look at the guidance that CMS has, that the only time you need to use that form is when you're going to be providing less than what the plan of care says. So for example, if a patient was receiving daily wound care for a couple of weeks and you were going to be cutting them down to once or twice a week based on the caregiver education or those kinds of things, that is when an HHCCN would need to be filled out. Unless it is completely mapped out on your plan of care, that's when you're going to cut that down. There's a need to have some collegiality between the patient and the provider when you're making that plan of care. The same thing needs to happen on the back end when you're lessening that plan of care. I hope that's pretty clear. And actually, it's going to make me go back and read it again to make sure that everything that I'm saying is correct. But the last guidance we have on that is from December of 21. So I would expect that we might see some further guidance coming up with the proposed rule in July. Usually comes around July 4th, everybody. And trust, you'll know about it because you'll get sick of hearing about it from me. Okay, last question of the day. And we might run about a minute over, but we started about a minute late. Home health contract therapy question and ride-alongs. Is it the responsibility of the therapy company or the home health agency?
Well, that's kind of a loaded question again with 1 minute left, Sherry.
It is. It truly is. But I'm gonna save you from it. I would be very remiss to say what is the responsibility of a therapy company or a home health agency if I have not seen the contract. A lot of those types of housekeeping visits, like ride-along, survey visits, those kinds of things, a lot of that should be in your language and already spelled out prior to making that decision. But I will say one overriding thing, Cindy, and you can please elaborate if you want to. The home health agency is responsible for everything.
Yep.
Okay. The home health agency, I'll say one more time, is responsible for everything. At the end of the day, the home health agency holds the Medicare license. And as that, you have to be a steward of that license and you will be held responsible, regardless of what that contract says. But I would definitely involve your legal team in finding that out.
And I would just echo that, Sherry, because contract is simply seen as a way you were able to access a service. and that ultimate responsibility for compliance and quality of that would fall to the agency. And as a former rehab director that worked with contract folks on our team, I rode along with them just like I would my own hired people, for consistency and to make sure it was going the way it was supposed to.
And with that, we're going to say bid everyone adieu and ask that everyone be safe when you're out on the road. And thank you for the awesome work you do in the home and keeping folks where they want to age in place. If you have any questions, please reach out to us at our email or at our website, www.valuebeyondthevisit.com. Thanks everyone for attending.